I have Dr. Yeomans here today, and he will be presenting over amniotic fluid embolism.
Good morning, everybody out there in the region and across the street. Kevin, I'm always glad to see you tuned in. Very happy to be here for this quarterly lecture. Although the topic is rare, it's certainly very important. I would like you to jot down on a little piece of paper next to you, because I can't wait for people to raise hands during the presentation. What do you think is the cause of this deceleration of the baby's heart rate? And what do you think is the outcome? Now, I caution you as you're writing this down on a little piece of paper that amniotic fluid embolism is very rare. And while it could be the first sign of an amniotic fluid embolism, there are lots of other things that could cause this deceleration. So some of you had the foresight to look at the bottom line. The contractions are coming too close together, and the patient is on oxytocin. Maybe the patient just received an epidural and had low blood pressure as a result of the epidural. Maybe more ominously, there's a placental abruption and the patient is bleeding vaginally. But one of the last things that should come to your mind is this an amniotic fluid embolism? So what I ask you to think about is always look at the mother when the fetal heart rate goes down. By definition, this is a prolonged deceleration. If it lasted 10 minutes, it would be a bradycardia. But look at the mom. Is she bleeding? Is she contracting too frequently? Is the monitor telling us the real story? How much Pitocin are we on? When did she get a top-up of her epidural or placement of an epidural? Common things happen commonly, and this is unlikely, though not impossible, to be the start of an amniotic fluid embolism. Let's look at terminology, because this is where everyone gets confused, especially people who deal with critical care relatively infrequently. This quote comes from Steve Clark about a decade ago. He said, because amniotic fluid is innocuous and the pathophysiology of this syndrome is not embolic in nature, it seems reasonable to conclude that the term amniotic fluid embolism is in fact a wrong term. It's a misnomer. However, it's been entrenched in the literature for 100 years, and I'm not going to switch during the course of this lecture. We're going to use the terminology that's out there, amniotic fluid embolism. This is a bit discouraging from Luis Pacheco. Unfortunately, it remains an unpredictable event, much like shoulder dystocia. No prophylactic intervention has been, I can go for that, or will be, that's where the pessimism comes in the near future, effective at preventing it. So the take-home point from this slide is two words: unpredictable, unpreventable. Therefore, whether you work in a level 1 rural hospital or a level 4 referral center like ours, you have to think of it. You have to react very quickly. Time is literally of the essence here. And manage what is often a dire emergency to the best of your ability. I titled this slide, The First Criterion. Amniotic fluid embolism occurs during labor or in the first 30 minutes after delivery. So guess what? This is not going to be something you're called to the postpartum floor for. It's not going to be a family care unit event. It's not going to occur in the antepartum period. During labor or in the first 30 minutes after delivery. That is so important that we call that the first criterion. In a recent review of registry data, and we're going to talk more about registries in just a few slides, only 20% of the women with amniotic fluid embolism delivered vaginally, and 80% underwent cesarean. A third of those cesareans were done in response to clinical findings of an amniotic fluid embolism. There is a term that is also time-honored in the literature called perimortem cesarean. Literally, it means cesarean done around the time of the death of the mother. The terminology on that has changed in recent literature to resuscitative hysterotomy. And what they're saying is, if the woman becomes unresponsive and has a cardiac arrest and you're starting CPR, somewhere in the first few minutes, you got to decide to get the baby out. And usually that means immediate cesarean delivery, sometimes done in the labor room. So Williams Obstetrics, which is for Dr. Worley and myself, considered the Bible. We both trained at Parkland. The 26th edition lists 4 diagnostic criteria, and they're really taken from Steve Clark's work in the American Journal back in 2016. Rule number 1, or first criterion as I called it, is unchanged here. Then you have to have a sudden onset of either cardiopulmonary arrest or both hypotension and respiratory compromise. In about 80% of cases, those are followed by overt disseminated intravascular coagulation. But in developing the criteria, one of the specifications was, don't confuse this with sepsis. So you can't have a fever. That's one of the 4 basic criteria. So in a recent series from France, only 60% of, and be careful now because the quotes are around autopsy confirmed. We'll talk more about that later. Only 60% of autopsy confirmed amniotic fluid embolism had all 4 criteria. So what that means is the criteria were very strictly selected for research purposes, and not all amniotic fluid embolism on the front end winds up being amniotic fluid embolism on the back end. The most frequent missing criterion is DIC. I'm going to show you some cases in just a few minutes, but in our case number 1 that follows, the only evidence of DIC was blood from the endotracheal tube. There was never any excessive vaginal bleeding. So I said we'd talk about registries. When events such as amniotic fluid embolism are uncommon and we don't understand them very well, we typically establish a registry, particularly if the topic is quite important, to accumulate enough cases to permit insight into diagnosis and management. So there are no great case series of amniotic fluid embolism to gain insight from. Where we get our insight is from analysis of registry data. And the US registry is not the only one. The UK has one, France has one. And after the cases have been submitted, they're subjected to review by a group of experts. So let's look at the US International Registry. 129 cases of possible amniotic fluid embolism were analyzed and reported in 2020 in the American Journal. Shown on the next slide is a pie graph of how the experts classified those cases, and it will open your eyes to the difficulty of the topic that we're dealing with today. The important take-home point, remember I put autopsy confirmed in quotes on a previous slide, is that even after a case that ends in maternal death, we still cannot be sure that amniotic fluid embolism was the cause. So here's how the experts divided those 129 cases. Let's look at the right-hand side of the pie graph. Typical amniotic fluid embolism met all 4 criteria. Roughly 50% of the cases that were submitted to the registry. Another small group of 15 were labeled atypical amniotic fluid embolism. Something was lacking, but it still walked like a duck and quacked like a duck, and therefore might have been considered a duck or some variation thereof. But surprisingly, 27 cases were firmly concluded not to be amniotic fluid embolism, and another 28 cases was indeterminate. The reviewers couldn't even decide what they were dealing with. So registries shed a lot of light on the process, but much of what I say that follows is going to concern typical amniotic fluid embolism. So in this same registry analysis, no definitive risk factors were identified. What they saw was a high rate of placenta previa, a high rate of patient-reported allergy or atopy, and IVF pregnancy. All three of those were observed in the registry data. So please bear these in mind when we review cases in just a minute. I think it's helpful for people in the region who are, most of whom, naive to this very important diagnosis, that before we examine what causes it and what the differential diagnosis is and how we manage it, it might be helpful to consider a few cases from the literature and one that occurred at UMC. These are very short. I've condensed the cases into 3 or 4 slides each, and I ask that you follow along and try to pick out a common thread and also be mindful of the 4 criteria that make a case an amniotic fluid embolism. So case number 1 is a 19-year-old G1P0 at 38 weeks who was admitted to the Family Birth Center here at UMC for induction of labor for non-severe preeclampsia. That is a very important little bullet right there. She's being induced for preeclampsia. She was receiving oxytocin, but contractions could not be traced well. It was decided to place an intrauterine pressure catheter, and membranes were ruptured. Providers reported fetal bradycardia. Remember that first slide that I showed you? Followed by seizure-like activity in a patient that's being induced for preeclampsia. Maybe your first thought is, she's having an eclamptic seizure. That would have been my first thought. The fetus, however, is very sensitive to hypoxia, and an acute change in fetal heart rate is often an early sign in amniotic fluid embolism. Moreover, seizures are seen in 20 to 50% of all amniotic fluid embolism cases. Then suddenly, between those 2 signs, seizing and a drop in fetal heart rate, there was complete cardiopulmonary collapse. The patient was moved to the operating room, and prior to starting the section, O2 sats were being reported in the 40s. And to tell you how significant that is, that's consistent with a PO2 of less than 20. Severe hypoxia. This is not this strip from this patient. I couldn't locate the strip from this patient, but this is what I mean about the first sign of amniotic fluid embolism. This actual tracing is taken from work by Steve Clark 10 years ago. Once we're in the OR, the patient became completely unresponsive, was noted to be frothing at the mouth and making grunting and gurgling sounds. After initiating CPR, a stat C-section was performed. Return of spontaneous circulation in the resuscitation literature, in the ACLS literature, this is referred to as ROSC. ROSC was never obtained. The baby was delivered fast enough to survive, but the 19-year-old mother did not. Why did she die? Well, we believe it was from amniotic fluid embolism, but there was no autopsy. You can lose a mother to eclampsia, but it's uncommon, and it usually results from an intracranial bleed, cerebral edema, and herniation. We don't have any data for that. But she met the criteria for amniotic fluid embolism in all of its various types. She was in labor. Membranes were ruptured. She had cardiopulmonary collapse. What about the DIC piece? We'll talk about that in a minute. Case number 2 is a 43-year-old gravida 5 para 4. So advanced maternal age, grand multiparity. All of her deliveries were vaginal, and at 36 4/7 weeks, she was admitted for heavy vaginal bleeding in the setting of a known placenta previa. Her vital signs were normal, and so was her oxygen saturation. Her hematocrit was 31%. She was taken to the OR, and a spinal anesthetic was administered. The C-section was uncomplicated, with delivery of a male infant with APGARs 8 and 9. So this happens infrequently. Placenta previa is maybe 1 in 300 to 1 in 400. every time from this presentation forward that I take a placenta previa to the back for a C-section, I'm going to be thinking about this presentation. 20 minutes after delivery, as the fascia was being closed, the blood pressure suddenly dropped to 70 systolic, the pulse went to 30, and the O2 sat went to 75%. That's venous oxygen saturation, not arterial. That's how low it is. The patient reported chest pain, then became apneic and unresponsive. Pulseless electrical activity was present. The trachea was intubated and CPR was begun, and the patient was given pressors. This case occurred at a large medical center. She achieved ROSC, had a transesophageal echocardiogram, and was placed on veno-arterial ECMO. Picture yourself just for a minute at a small rural hospital. No ECMO capability, no transesophageal echo. Even at the big medical center here in Family Birth Center, we don't have immediate access to a transesophageal echo, nor do we have immediate access to ECMO. So the providers gave glycopyrrolate, which is an atropine-like drug, vagolytic drug, 0.2 milligrams, and 2 boluses of 1 milligram of epinephrine, and they started an epinephrine drip. She survived with unknown neurologic sequelae. Transesophageal echo. Imagine now that we're putting an ultrasound probe down through the mouth and into the esophagus, and this is the first picture we get. This picture shows, and I don't know if I can make my pointer work here. Where is my pointer, Jesse? Is it somewhere? Okay, put it on the right atrium. Right there. So the right atrium is dilated, and the interatrial septum is shifted to the left significantly, and the right ventricle is not yet very dilated. Now we see that the right ventricle is pumping against a significant resistance, which, as we'll see later, is caused by pulmonary vasoconstriction. And it blows blood back through the tricuspid valve and into the right atrium. So this jet here that we see, whoops, where's my pointer? This little colored jet here actually represents tricuspid regurg, coming from the right ventricle into the right atrium, caused by intense resistance to the right ventricular pumping function. Now we're going to shift our attention from the atria to the ventricles. And you see a relatively small left ventricle, a large, distended, dilated right ventricle, and a shift of now the interventricular, not intraatrial septum, to the left, which is called a D shape of the left ventricle. This is severe right heart failure. 24 hours later, the echo looked pretty normal. What about an epinephrine drip? Sometimes during a resuscitation, bolus administration of epinephrine results in wide swings of blood pressure. These people were in the operating room with anesthesia at the head of the table. It was no problem for them to rapidly mix an epinephrine drip. How would we do it? Are our labor and delivery nurses at the level 4 center capable of quickly mixing an epinephrine drip on request? Well, my contention is yes, you should be, but I don't think many are. And in the rural setting, even fewer. So to make a drip, add a milligram of epinephrine to 250 milliliters of either D5W or normal saline. That will result in a solution of 4 micrograms per ml. Usual starting dose of epinephrine is 10 micrograms per minute, which then gives an infusion rate of 2.5 cc's or milliliters a minute. So the important equation at the bottom should be known by all doctors and all nurses. Dose equals concentration times infusion rate. That's true with oxytocin, that's true with magnesium, that's true with every drip that we use. But if you're going to start an epinephrine drip, somebody, usually anesthesia, critical care person, critical care nurse, somebody has to know how to run the drip and make sure you don't pour the epinephrine in wide open. Let's look at a third case, a 35-year-old gravida 4, para 1021 at 36 and 4/7 weeks, admitted for planned repeat C-section for placenta previa. So let's go back a few slides. I'm not going to turn back there, but in your mind, let's go back to the 3 things that the registry showed. A high rate, unexpectedly high rate of placenta previa associated with amniotic fluid embolism. This is our second case of placenta previa among the first 3 cases that we've presented. The ultrasound did not show any evidence of accreta. Another worry with a placenta previa and a prior C-section, is there a placenta accreta? And in one of my previous lectures, we talked about placenta accreta spectrum. So these physicians performed a low transverse C-section, delivered a baby with Apgars 8 and 10, and the placenta was removed with gentle traction. While they were using a gauze to remove the clots from inside the uterus, a lap, the patient became unresponsive to at least verbal stimuli, but had a pulse. Only 2 minutes later, she was pulseless with normal sinus rhythm on the monitor. So this is another case of pulseless electrical activity. And this is one of the ACLS algorithms. And it's one of the reasons that everybody that works here at UMC in labor and delivery has to be ACLS certified. CPR was begun, the trachea was intubated. Once again, a great advantage, anesthesia is present. We're already in the OR, we're under spinal, but immediately the trachea was intubated and ventilation begun. 30 minutes after the C-section, she developed a severe coagulopathy with the lab values shown here. This patient presented with a cardiac arrest. 87% of all amniotic fluid embolism cases have a cardiac arrest. While undergoing active resuscitation, people are pumping on the chest. Picture this now in an OR in labor and delivery. Now they have somebody to perform a transesophageal echo. This is remarkable that they can get that fast. She was treated with inotropic agents and inhaled nitric oxide. We'll talk about that a little bit later. And she too survived. So what about these last 2 cases, case 2 and case 3? What do they have in common? Well, there's several similarities. Both patients were advanced maternal age. Both had placenta previa. And both occurred in an OR immediately post-cesarean with anesthesiology at the head of the table. There was no delay in initiating CPR. Excuse me. Case number 4 is an atypical amniotic fluid embolism. You remember the pie graph? There were typical amniotic fluid embolisms and atypical amniotic fluid embolisms. This lady was 26, G2P1 at 38 and 1, who presented to the ER with a temp of 102. So Williams Obstetrics and Dr. Clark would rule out this case because one of the 4 criteria was no fever. She was statting well, her blood pressure was good. They noted that her cervix was at 1 centimeter with intact membranes, and they proceeded with a stat C-section under general for a category 2 tracing. We might have watched that for a little while here, but they went right away. And they began to give the patient broad spectrum antibiotics. At the time of C-section, meconium stained amniotic fluid was noted, but the Apgars in the baby were 9 and 9. The reference for this case is down in the right-hand corner. But Dr. Cunningham, writing in Williams Obstetrics, says that when amniotic fluid finds its way to the lung, it's usually worse if it's meconium stained. Keep that in mind. Immediately after delivery of the infant, but before delivery of the placenta, oxygen saturation dropped to 72%. The blood pressure decreased to 72/48. And the end tidal carbon dioxide dropped from 32 to 0. Normal range is 35 to 45. The AOK regimen was given IV within 1 minute. A is atropine, 0.2 milligrams, which is a vagolytic drug designed to combat bradycardia. 8 milligrams of ondansetron, which is Zofran, which is an anti-serotonin drug, and 15 milligrams of ketorolac. And oh, by the way, she got 1,800 mics of phenylephrine in divided doses. So the AOK regimen, although it looks good on paper, is the subject of only case reports, and it has not found its way into standard management of an amniotic fluid embolism. Let's look at the Bohr equation, a little science. I taught you how to do an epinephrine drip. I'm going to teach you how about the Bohr equation. It has to do with gas exchange in the lungs. So the equation is there for you to look at. Let's look at this case where they report to us that the end tidal CO2 is 0. So let me get my little pointer out here and see. Right here, this term right here is 0. So that leaves me with PaCO2 in the numerator and PaCO2 in the denominator, and that means the right-hand side of the equation reduces to 1. That also means that the dead space volume is equal to the tidal volume. If by capnography the end tidal CO2 is 0, then the entire pulmonary system is dead space and no effective gas exchange is occurring. That's why we get this respiratory collapse. It can precede the cardiac arrest, but the respiratory collapse means that the blood is black and there's nothing perfusing the uterus. It's really catastrophic. However, within 3 minutes of giving the AOK regimen, O2 sat improved to 97%, the blood pressure returned to normal, and the end tidal CO2 returned to normal. What made this case atypical? Well, we already said the presence of fever and the fact that the patient never went into DIC. The AOK regimen has not been tested in a series of patients with presumptive amniotic fluid embolism. This is our last case, 34-year-old Gravida 3 pair 2 at 38 and 6, admitted to a rural community hospital in the Midwest. Think about Seminole. Think about Brownfield. Think about a rural community hospital in our region. At 3 p.m. in the afternoon in early labor. Shortly after midnight, she had the sudden onset of dyspnea and chest pain. Her eyes rolled back and she became unresponsive. Her SATs dropped to 74% and the fetal heart rate went to 60. Well, if you're in a rural center listening to this talk today, this should strike fear in your heart because this is a report from the literature, but there before grace go you. If this occurs in your center, this is catastrophic to have a patient become unresponsive and all those changes taking place. In this case, she was completely dilated just after midnight and underwent a forceps delivery. Really reasonably rare out there in rural sector America, I would say. The Apgars in the baby were 5, 6, and 9, despite that heart rate that dropped to 60. The placenta was delivered 8 minutes later, and in the next 5 minutes, her pulse was 170, blood pressure 57/37, and saturation 78%. She never had a cardiac arrest. 87% of amniotic fluid embolism presents with cardiac arrest. But she did develop severe DIC, underwent an emergency hysterectomy, and died 12 hours postpartum. Now, with those 5 cases fresh in your mind, let's talk about pathophysiology for this condition. First, there is disruption of the maternal-fetal interface. Way back in our first case, the membranes were ruptured and an IUPC was placed. Something innocuous that we do every day, we put IUPCs in. Amniotic fluid and its contents then reach the maternal right heart and from there to the pulmonary circulation. What follows are maternal cardiovascular effects, maternal hematologic effects, if undelivered, fetal effects. And we'll consider each one of these separately with some great diagrams. So this is difficult to see out there where you are, but I'm going to break it up into two separate slides. But essentially in the top left corner, it says what I just said on the previous slide. Amniotic fluid and its constituents make it to the pulmonary circulation. But then it's not really the fluid itself or the contents of the fluid. It's the maternal response to those antigens that unleashes a cytokine storm and gives us the pathophysiology of this condition. And on the right-hand side are maternal cardiovascular effects. In the middle is maternal hematologic effects, and on the left is fetal effects. So let's break it down and look at a little larger rendition here. Disruption of the maternal-fetal interface. In the European study of 36 cases of amniotic fluid embolism, all of them had ruptured membranes. It didn't say how many were artificial and how many were spontaneous. All had ruptured membranes. So that maternal-fetal interface has been disrupted and allows amniotic fluid and procoagulants and fibrinolytic activators to gain access to the maternal circulation and contributes to the development of the AFE syndrome. Over on the right-hand side of this slide, it says, abnormal activation of immunologic processes lead to vasoconstriction of the pulmonary vasculature. So what happens then? Now, as you constrict those pulmonary blood vessels, the right heart has to work harder. It will dilate. It will fail. It will cause acute cor pulmonale. The right side of the heart is going to be challenged by this widespread pulmonary vasoconstriction. And then blowing up the bottom of that first picture that I showed you, there's going to be a shift of the interventricular septum as shown on the right-hand side. My pointer, whoops. Right here, bring it up here. Okay, so you can see that dilated RV shifting the interventricular septum. In the middle, you see the coagulopathic aspect of DIC due to prothrombotic substances that make it to the maternal circulation. And on the left-hand side, you see uteroplacental insufficiency and hypoxia and an abnormal fetal heart rate. This slide is taken from Williams Obstetrics. It shows you how fast the onset of thrombocytopenia is. That's the triangles. The dark blue dots are fibrinogen. So the fibrinogen gets down to 50. The definition of overt hypofibrinogenemia is less than 150 milligrams per deciliter. And the fibrin split products go way up, which is the red circles. So by now, you've listened to 5 cases, and a very common element is low blood pressure. Difficulty breathing is common. Because the patient becomes hypoxic, she will have blueness around her lips and her extremities, her fingers, and that will spread to the entire face, cyanosis. Our patient in case number 1 was observed to be frothing from the mouth. If the baby is still inside, the tracing will become abnormal. The patient will undergo loss of consciousness and potentially seizure activity. Most of the time, there will be a complete cardiac arrest. And later in the course, if she is resuscitated, she'll begin bleeding from the uterus, incisions on the skin and the uterus and the fascia, and IV sites. We have to consider a differential diagnosis, but really, if you take all these things we've talked about today in toto, it's pretty easy to rule out all the way down. However, go back to the pie graph. A number of submitted cases did not convince the experts that they were dealing with an amniotic fluid embolism. maybe there was one of these other explanations involved. So regrettably, we don't have a definitive diagnostic test for amniotic fluid embolism. It's a clinical diagnosis. A transesophageal echo or transthoracic echo can be helpful, but you have to mobilize it really quickly, and you have to have somebody there who knows how to do it and interpret it. Since amniotic fluid embolism frequently begins with cardiac arrest, the initial immediate response should be to provide high-quality CPR. So in Dr. Pacheco's article in the gray, and this is one of two very important references for this lecture. This is something you can search online as a 4-page article. And the beginning of the article, it'll make you think you're an ACLS because they emphasize high quality CPR. If you don't restore the circulation, the patient is not going to get to a transesophageal echo or transferred to the ICU or ECMO or anything else. Your CPR has to restore the circulation. And then Pacheco talks about other measures. So he says, as soon as feasible, transfer the patient to an ICU. Start some pressors. Remember, the one patient with the AOK regimen also got 1,800 mics of phenylephrine, which is pure alpha. Inotropic agents include milrinone, dobutamine, pulmonary vasodilators like epoprostenol and nitric oxide. Avoid fluid boluses. The heart is already working hard. You don't want to put much crystalloid into the IVs. What you want to put is blood products, especially in the presence of DIC. Even before you have DIC, it's a good idea to activate the massive transfusion protocol. And then if you're at a center that can provide it, which basically none of us who are participating in this lecture today are at such a center, we could consider veno-arterial ECMO. So this is the second publication that I want you to get and then post the checklist in all labor and delivery units. This appeared in April 2021 in the American Journal, page B30. One of its major features is that it provides doses for uncommonly used drugs in a labor and delivery setting. So who uses nitric oxide or epoprostenol or milrinone or many others? So we wouldn't know, most of us working in labor and delivery wouldn't know the first dose to start. We might know from ACLS the starting dose of epinephrine. So I'll leave you with these conclusions. Amniotic fluid embolism is blessedly rare. The incidence in Williams obstetrics is quoted at 1 to 2 per 100,000 deliveries, but other sources say that it can be from 2 to 8 per 100,000. You could hope, I guess, that you never see one in your whole career. But if you do, knowing just a little of what we discussed today may save the life of a young mother. This is my 44th year in the field, and I've seen 5. Only the first one made it. All the rest died, and they were all young. I'll take some questions from the field. You can text them into Mallory, and she'll relay them to me.
We'll also post the QR code in the comments so that you guys can fill that out and receive your CNE, and we'll email those to y'all. Dr. Worley said, thank you for the presentation. Okay, everyone, thank you so much for attending today. If you'll fill out that QR code, we'll get that CNE to you, and just let us know if you guys need anything. Thank you for attending.